Welcome to Somerset Medical Center's Health Talk show. I'm Dr. Douglas Ashinsky of Warren Internal Medicine, an affiliate of Somerset Medical Center. Cancer continues to be one of the leading causes of death in this country. Over the years, as we've learned more about what causes cancer and developed enhanced methods of early detection, we've been able to prevent the disease and identify it in earlier, more treatable stages. Lung cancer deaths, however, continue to remain high, making lung cancer the most deadly cancer. New studies have shown the benefits of annual screenings for lung cancer in high-risk individuals. And we have been seeing a steady decline in the number of people who are smokers. On today's show, we'll talk more about lung cancer, the new screening recommendations, and help for smokers looking to quit smoking. I'm pleased today to be joined by Dr. Robin Lucas, pulmonologist at Somerset Medical Center, and Dr. Chris Kotsen, manager of Somerset Medical Center's Tobacco Quit Center. Thank you both for joining us on the show. We'll start with Dr. Lucas. Tell us a little bit, tell the audience please a little bit about lung cancer, causes, what it is, how it's detected. Give us a whole overview of lung cancer.
Lung cancer, by definition, is a tumor that originates in the airways or the lung itself, and it is clearly related to smoking and tobacco use. The overall tragedy in this is that it is now the leading cause of cancer in men and women, and since 1987 has surpassed breast cancer in women as the leading cause of death. The biggest problem that we've had with lung cancer is early detection. We've really had no good tools to detect the cancer early. And as the public and physicians are well aware, the earlier that you find a tumor or a cancer, the better chances of your survival. It should be noted that when an individual is diagnosed with lung cancer, their 5-year survival is 15%. And this number has not changed since 1970. So the problem has been early detection. Usually, when patients present to a physician's office, they will have some symptoms of cough, shortness of breath, funny feeling in their chest, or weight loss. Some can cough up blood. If this is the case, the tumor size is usually too big and they are not candidates for cure. So we really needed some type of tool to be able to detect a cancer early. And chest x-rays have been woefully inadequate. Studies have shown since the 70s that was the only tool that we had, and with the onset of CAT scan, we then began to look at this as a better tool.
As a primary care physician, I've been in practice now for 28 years. Again, we used to do the annual chest x-ray as part of the routine physical, and then back in the 80s came the study that basically said we weren't finding them any earlier by doing that annual chest x-ray, so we stopped basically doing that annual chest x-ray. We do a chest x-ray when the person comes in with symptoms, and as you've described, by the time they come to those symptoms, it's probably an advanced cancer.
Absolutely. Those studies showed that early detection with a chest x-ray was futile. They had even compared doing bronchoscopies early, chest x-rays early, sputum collections early, and it did not change the overall outcome. With the advent of CAT scanning, we now have a better tool. There was a National Cancer Institute study that involved over 53,000 patients that started 8 years ago at 30 centers, and they looked at using the CAT scan as a better tool to screen. And what was remarkable is that they found significant drop in mortality of 20% using CAT scans over chest x-rays. And having said that, the National Cancer Institute then launched the lung screening trial, which other hospitals are now mimicking to use as a tool as an early detection. And I'm very proud to say that Somerset has also taken this on under the direction of Katrina Losa, the director of Steeplechase.
Okay, tell us more about this CT scanning recommendation, who we recommend to have it done, who high-risk people are, and what Somerset is doing with this.
What the National Cancer Institute did was look at high-risk individuals, and who they defined as high-risk individuals were 55 to 74-year-old age group, those that had a significant smoking history, which was defined as at least 30 years of a pack or more a day, and having quit within a 15-year time frame. The other important quality that they included were occupational history and family history, because we know, second to smoking, if you have asbestosis exposure, various chemical exposures to arsenic, nickel, diesel fuel, asbestosis, this also puts you in a high-risk category because of occupational exposure. They also looked at family history. So the National Cancer Institute, in their study, took these same individuals, as did Somerset at the lung cancer screening, to mimic their study. And I'm proud to say that we launched it in February of 2012. We have looked at over 252 individuals and have found 7 early detectable cancers for cure since then.
So let's go back a little bit. High-risk people are going to be people who are 50 to 75, who've smoked at least 1 pack a day for 30 years or more.
Correct.
Those who have secondary factors also, such as they work with asbestosis, diesel fuel, other types of chemicals also.
Correct.
These are the people that are in a high risk and therefore should be considered for the CT scanning screening.
Correct. Absolutely.
And Somerset Medical Center has such a CT scanning screening.
It's a collaborative effort amongst radiologists, myself, local pulmonologists, and the oncologists, as well as Dr. Kotsen's group for smoking cessation, which that triad is key in able to help the patient stop the habit as well as early detection.
Okay, so the people who are eligible, can you give me a list of, or the characteristics of who's eligible for the screening?
Usually it's the individual who has smoked at least a pack a day for 30 years, and we call that a 30-pack year history. You can smoke 2 packs a day for 15 years, but it's still the same. You take the number of cigarettes, packs, times the number of years that they smoked to put them in the risk category. Also those that have worked with asbestosis, people that have worked with jet fuel. We've had some individuals that have done cleanup at ground zero, that have had significant exposure to polyvinyl chlorides and byproducts that are carcinogens. And also family history. Mother, father smoked. They also had a history of lung cancer. There have been some individuals that have been involved with twin studies that have also had lung cancer that we've enrolled into the screening program.
And insurance, does it cover it?
No, the insurance does not cover it. But it is remarkable that Somerset has been able to do this project for $99. And that $99 includes not only having the low-dose screening CAT scan done, but they meet with myself to review the scans and the risk factors, as well as consulting with Dr. Kotsen for smoking cessation, which is key. You can make an early detection for a cancer, but unless you stop the driving force that makes you have the cancer, it's really falls through. We also perform lung studies or spirometry to show the individual if there is a degree of underlying lung disease based on their smoking history. And I'm also proud to say that Somerset is the hospital that has done this in the area where others have not, and have been able to do it for $99. And I think that that's a wise investment for any high-risk patient to be able to do. I would like to add that if there is any abnormality seen on the CAT scan, in hindsight, then the insurance company will pay for further testing.
Well, it's nice. $99, it's less than what Lifeline charges people for the testing that they do.
Good point.
And you also get a physician consult with it.
Correct.
So these high-risk people really have good reason to come here and do this.
They're actually relieved when they come there, whether they have findings or not. I think that in the back of their minds, the people with a significant smoking history feel that if they can't really stop the habit right away, maybe they can be proactive and look at things, because the patient and the population is educated about the dismal outcome of lung cancer.
Okay. Now, as you know, because it is a CAT scan, some patients are going to be a little bit leery about being subjected to radiation. Can you tell us about what the exposure is when they have the CT?
The exposure, and a lot of patients ask this all the time, the exposure is minimal because it is a low-dose CAT scan, number one. Number two, that's why we look at high-risk individuals, and the data is out there at 50 or greater. There is minimal risk. It's not reproductive years. And also, you're not adding IV contrast or the dye which can have a radioactive element to it, which we do not use.
So we're using a low-dose CT scanner on the high-risk people, and therefore we're not increasing their radiation exposure, and therefore they're getting a good screen with minimal complications.
That's absolutely correct.
And when the scan is done, when do they find out the information? How do they find out the information? And what's done with the information?
Once the scan is completed, there's usually a 1-week turnover time where they're scheduled to meet with me and Dr. Kotsen in the lung cancer screening clinic at Steeplechase. But again, it's usually a 1-week turnover time unless the individual cannot make the schedule. But we meet once a week, every Wednesday, from 11 until 3, pending on the amount of patients we need to see for that lung cancer screen. And it's about a 30-minute visit.
And the information that they receive at that visit?
I will sit down with them on a one-to-one basis, actually show them the scans, discuss all the possibilities based on their history for what could be there. And you don't necessarily pick up lung cancers or tumors or clumps of cells, but there's other things, incidental findings that one can see on a CAT scan, particularly from old pneumonias, old scarring. You can see evidence of what we call nodules or spots, which are little clumps of cells that may be benign. We also have picked up tumors elsewhere in the liver, in the kidneys as incidental findings, which again correlates with the same results seen from the National Cancer Institute. So overall, it benefits the patient.
Very nice. Now, Dr. Kotsen, tell us more about the Tobacco Quit Center at Somerset Medical Center, the services that you provide, how people get in contact with you, and what we can do to help reduce them from smoking.
We provide specialized individual and group treatment to treat the behavioral components of the habit, changing the habit, and also we use the FDA-approved medications to help with the physical cravings, which treats the physical addiction. In regards to the Lung Cancer Screening Center, as Dr. Lucas mentioned, we've now expanded to seeing patients for that follow-up visit. So those folks that are continuing to smoke and recent quitters, we will have a brief treatment visit with them. And of course, some of those people will quit as a result of that or enroll into our program, which is weekly meetings.
Now tell us about the program.
So basically what we do is we provide the specialized treatment. As I said, we meet once a week. A typical patient would come about 4 to 6 weeks. Some people choose individual meetings. Some people choose group meetings. And there are different advantages to group, of course, which we can get into. And as I said, the medications work on the physical part of the cravings. We also want to help to minimize the withdrawal symptoms. So if patients are calmer and they're not having irritability and anxiety and concentration problems, they can work on all those triggers that are related to smoking, like getting through the urge in the car, getting through that urge after a meal, or handling the sight and smell of tobacco when other people are lighting up around them. So it's a comprehensive one-stop shop, basically.
Okay, so the person's come to Dr. Lucas, had the scan done. Thank God it's normal. They're a 30-pack smoker or greater. You're sitting in there with them now also. You're having your consult with them. Tell us what's going on.
Okay, so one of the things we do is we review some of the chemicals in tobacco. We look at their history, their level of addiction. Are they using menthol cigarettes? We talk to them about their desire to quit. We talk about prior plans of success, lack of success. And then, as I said, we start to work right there on some of the trigger situations, and we can offer them medications, the 7 FDA-approved medications, including combinations. So we'll set up a quit plan for them. As I said, some of them then will continue with us on a weekly basis. Some of them will work on it on their own or with their own physician.
Okay, so you're going to go through the different ways of getting them off of cigarettes, including cold turkey?
Right, so good question. Cold turkey comes up a lot. A lot of people have tried cold turkey. And we always say that, to use an example, if you take 100 people going cold turkey in January, only about 3% of them are going to be successful at the end of the year. And let's just define it. Usually that means abrupt quitting, instead of gradual cutting down. Usually that means not using any medications to handle the withdrawal symptoms or professional help. In fact, if you follow those 100 people up, by February, 75% of them are smoking, and that's how quick relapse happens without evidence-based treatment.
Okay, so the person's coming to you. You're going to help them get off the cigarettes either through medication, cold turkey. You have any other ways that you're going to be doing? Are they going to be sitting down with a psychologist, clinical? What else are they going to be doing?
That's right. So all of our clinicians, I happen to be a psychologist, but I'm a certified tobacco treatment specialist. All of our clinicians have specialized training. As I said, we wouldn't recommend cold turkey, but we would recommend the behavioral counseling along with the medications. So for example, let's talk about group counseling. So the advantages of group counseling, and our center has shown this as well as other centers across the country, is that the success rates are about 15 to 30% higher above and beyond individual counseling. So try to envision it for a second. If you think of a smoker who started as a 13 or 15-year-old, they started smoking in a group. So quitting in a group is tremendously effective. So the learning process is expedited in group. If someone's sitting with 4 to 8 other quitters on that journey to quitting, maybe 2 or 3 of them have just quit, and they're learning about how to overcome cravings after a meal, how to overcome those cravings when they're around smokers. So they learn quicker, plus the social support helps with the isolation and the stress that's involved in the quitting process. And then, of course, they're going to experientially see people succeeding with at least 1 or 2 of the FDA-approved medications. They're going to learn what's withdrawal, what's a possible small medication side effect, and they're really going to, we're going to treat the whole person. So that's a big part. Almost half of our smokers choose group.
Okay, so that's how you do it from when Dr. Lucas sends them. How about someone coming to you who hasn't gone to the CT scanning? You see them also, and do you help them also?
Right, so anyone outside of a CT scan can call the Quit Center at any time and see us, and we'll see them. And as I said, part of that individualized, tailored quit plan will involve an assessment of all components of the addiction. And then, as I said, we would add in the 7 FDA-approved medications and combinations of them often.
And your success, do you have any good success stories for us? Right.
The success stories, we always want to start with what's the success of doing nothing. We'll cold turkey, I said 3%. One of the key things to understand is that you, because of the severity of the addiction with the tobacco, it could take 20 tries to quit for a typical 40-year-old smoker. And why is it so hard to quit? Well, one, additives. The tobacco companies have put in additives like menthol that mask the harshness and make the cigarettes more addictive. So menthol smokers have to try harder. And then 2 is the physiology itself. The smokers get rapid delivery of nicotine from the mouth to the lungs to the heart, and then the artery shoots it to the brain in about 7 to 10 seconds. So that causes the enjoyment. And then, of course, when you wean down from that, you go into the withdrawal symptoms. So it makes it hard to quit, but with our comprehensive program, our success rates are 35 to 70% have quit at 6-month follow-up. Of course, the folks that get closer to 70%, most of them have used 2 medications and have completed at least 4 visits. If you just come for 1 visit, you're going to be on that lower end.
Insurance coverage.
So good question. There's a lot of hype and a lot in the news now about the Affordable Care Act. The Affordable Care Act actually has tobacco cessation mandated as covered in treatment. And it's been shown in studies that it's the #1 cost-effective preventive service. So along with mammograms and colonoscopies, it's now a covered service. So we're seeing more and more plans cover it, and not only cover it, but it's covered at 100% with no deductibles. Now, there are some exclusions, and for those plans that have exclusions, we have a discounted self-pay fee, so it's less than the cost of smoking. So we've set it up that way that all groups can come in, and we take walk-ins at any time.
Very nice. Now, again, I'm a primary care physician. I'm going through my patients' regular routine medical annual screening. I have that question that asks, are they a smoker? My answer is yes. How do I now refer them to you?
The simple way to do it is with a fax to quit referral form. We have most of the physicians at the hospital that are aware of it, and it's actually a teachable moment, of course, and the patient just fills out the form, the physician faxes it to us, and we will chase the patient. We will call them, we will help them get linked up with an appointment, and that's the easiest. Of course, patients can call us directly, or they can walk in. In most cases, we can see them within that day.
Now, you brought this device in to show us a little something.
Part of the assessment is every visit, the patient gets the breath carbon monoxide test. See, the old thinking is a patient comes in and they say, well, I give in to the cravings. Well, what we like to do is to break it down and help them see that the cravings are caused by nicotine, which is not the poison. The poisons include carbon monoxide, and this measures carbon monoxide. We go over some of that, polonium, which, by the way, is radioactive, arsenic, cyanide. What we do is we give them an experience with this. Now, the carbon monoxide blocks the oxygen, and a lot of our smokers have shortness of breath, or they avoid exercise or fatigue, and we measure this in every visit. This also helps us with our assessment in assessing a level of addiction, because different smokers will inhale at different rates. So if you inhale deeply, your score is going to go higher on this. Now, this bridges the body and the mind in that it's biomedical feedback. As the smoker cuts down in subsequent visits, a week later, 3 weeks, they'll see the numbers drop. And then within 1 to 2 days of quitting, it's completely cleared out. So we link this with the improvement in breathing and stamina, and patients get very inspired by this.
So we have a nice objective way to show them that they're reducing their smoking habits.
Exactly.
And it's a number in front of them, which makes it much more meaningful for them.
It's much more tangible. It's an experience, just an idea.
Very nice. Well, the two of you have brought us a lot of information about lung cancer. Dr. Lucas, do you want to add any last things about, in addition to smoking, other risk factors for lung cancer, other things that patients should know about?
I think the important take-home point is that Somerset Medical Center Steeplechase is being responsible to the community by launching this program for $99. When I've spoken to colleagues at other facilities, it's as high as $300. So we really have done a great deal of work in helping the community. Other cancers that you have to be worried about, again, radon exposure, arsenic, nickel, diesel fumes, things that Dr. Kotsen had talked about. Secondhand smoke, of course, is another culprit. And again, the 55 to 74-year age group, the number of years that they've smoked and the number of packs that they've smoked, family history of cancer, occupational exposure is key. The other important thing is that we've now proven through this great study done by the National Cancer Institute that there is a 20% drop in mortality with early screening. It's far more superior than chest X-ray, and CAT scan low-dose radiation is very important. And I hope in the next 5 to 10 years I can come back and say to you, you know what, the 5-year mortality has changed in lung cancer, and we've really changed it since the 1970s. So hopefully this screening will make an impact.
Any last messages for people who want to quit smoking?
The Tobacco Quit Center is part of the Lung Cancer Institute, where we're treating the whole person. Also, remember with tobacco is that quitting takes practice, so don't give up on quitting. And we have the tools that can help. We've treated over 3,000 smokers. We can help you succeed and take control of your health.
Well, thank you both for coming in to see us. Thank you for Dr. Lucas for giving us those statistics. It's unfortunate that still a 5-year survival rate's only 15% with lung cancer. Hopefully with everything that you're doing and everything that you're doing, we can hopefully improve that rates and that next year or the year after when we do this again, we won't have to say 15%. We can say a much higher percentage of people living after having been diagnosed with lung cancer. And hopefully, I hate to say this to you, but maybe down the road, we won't need a quit center because people will actually be quitting smoking. Hopefully, with all of the efforts you've put in and will be putting in, we'll get that quit rate down much, much lower than it currently is. And that instead of them only being a 15, 20, up to, it'll be a 70% quitting rate. And that's, as I said, I'm sorry to say this, but maybe you'll have to do something different because people will have quit smoking.
That sounds great. It'd be a nice achievement.
This concludes today's episode of Somerset Medical Center's Health Talk. Please remember that the opinions expressed here by our medical experts are not a substitute for medical advice from your own physician. If you need a physician, please call our physician referral line at 1-800-443-4605. For more information about the lung screening program at Somerset Medical Center, visit steeplechasecancercenter.com. Thank you both for being guests at our Health Talk show.